Okay, thank you, Bashir. Assalamu alaikum, everyone. Assalamu alaikum, who are on the line as well. And thank you for being here with us. Let's start the first debate. I think very interesting topics which we have today here this morning. We'll have 8 minutes of the talk and from each side, and then 2 minutes each for rebuttal. So we're going to start with the first topic, which is complex PCI should only be performed in centers of excellence. Dr. Najib Azam from UK is going to be speaking in favor of this motion. Najib, it's over to you.
Share my screen?
Yeah, we can see you. And
can you see my slides as well?
We have your slides as well, yes.
Okay, so good morning, Assalamu alaikum. When I got this topic, and I was pro for this one, I thought I've got good friends in course directors and people organizers, so I was very happy. When I looked at the time, then I realized they're not really true friends. It's 4 a.m. in UK. In UK. That's the hospital I work in. Can you guys hear me? Oh, you can hear me. Howard, can you hear me?
It got a little interrupted. Yes, we can hear you now. I think there was a little interruption.
Okay. So debate is about the complex PCI should only be performed in center of excellence. And I'm for the pro, and I feel sorry for my dear esteemed Honorable Dr. Azan Khalid that he has been given a difficult task to defend, to go against this. Basically, when we talk about center of excellence, does it mean high volume? Does it mean surgical center? But never mind. We have got a debate and we got to follow some rules. I'm not sure what are the rules, but will this style of debate will be for the American people? Is that their style, or we are in Lahore, or we have to have a Dangal style debate? But I'm sure Rizwan will agree that we should have a gentleman style debate. So this is a national audit of percutaneous coronary intervention in the UK, which was presented about 3 years ago. And this is some data from NICOR, which is National Institute of Cardiovascular Outcomes Research Center. It's a British Cardiac Intervention Society data. I mean, they do recommend that the PCI is a complex procedure. Does require the interaction of a number of different members to optimize care, and teams are performing enough procedure for them to remain familiar with all the process involved. A center that performs a small number of procedures is described as a low volume center. So to me, center of excellence, rather than center of excellence, we should be talking about a center which performs a higher volume. And I think that's an important, and I personally think majority of the PCIs, maybe all, but at least complex PCI should be performed in a center which routinely performs high number. Okay, can I go to the next slide? I'll go to the next slide. Sorry about that. Okay, now I'm going to go. I think their numbers are a bit arbitrary. They say it's about 400. UK, they recommend the most of the high volume centers should perform about at least 400 cases a year, which basically less than that, they think it'll be too low for experience and providing an optimal care. These are the recommendations. Although they looked at it, there's no real data to suggest that the lower volume centers were putting patients at risk. But nevertheless, I think one of the reasons was in UK, lower volume centers try not to perform the complex cases in their centers again. So what is the complex PCI? So, and why these higher volume centers or other centers are better for the patient point of view? First, I think there need to be an MDT process, and for MDT, you need to have a heart team, which includes the cardiac surgeons, cardiac anesthetists, and intervention cardiologists, and nowadays, if patient has associated aortic valve disease, then TAVI operators. Then in that center, how many number of experienced operator present? We know that when we have a problem or a complex situations, we do look for a friend, we look for a buddy. Then if you are the only operator or only experienced operator, it becomes difficult. Then how many cath labs you have? We think you need to have a minimum 2 cath labs, because if you have a problem with a lab, then you can take the patient to the next lab. So you should have a true functional lab. And then the lab access should be 24/7, because all the staff and everybody should be available 24/7. You've done a complex case, but you have to go back to the cath lab. Then you realize, oh, it's 3 a.m. It's very difficult. So I think the number of labs are also important, and then is a 24/7 ability to function is important. When doing a case, in a complex case, sometimes it's long, sometimes it's tiring, and it's good to have another eye, another pair of eyes as well, and a brain. So if you don't have another experienced operator, but you need to have some PCI fellows with you in the lab, in case if something started to go the way you don't want to go. So again, and the cath lab staff as well, how experienced they are. If you want to have a rotablator and they have no idea how to get a console out, or how to give you a pressure wire, how to set it up, or how to get you an IVL, lithotripsy or shockwave balloon, I think it becomes also difficult. So you need to have an experienced cath lab. The problem is that some of these things you don't do every day, or at least even in the experienced labs, people don't have huge experience every day, but they have a reasonable enough experience that not to panic, and obviously they will take in a minute or something, set it up. Then you need to have a 24/7 good medical care, nursing care, allied health care, and the echo service. Obviously, all the procedures done and the patient looked after by rest of the staff. And again, if they are not experienced to look after the complex patients, then I think will be difficult. In that scenario, I would say it's better to avoid. Okay. Then it comes to the equipment point of view. Do you have a rota? You have an IVUS? Do you have an OCT? You have an IVL balloons? Obviously, these are all expensive stuff. If you want to keep on shelf, they have a shelf life as well. And then if you're not using it, then it's a problem. It's in a small labs, and we are less likely to use. Then you have consumables. Do you have stents of all sizes, balloons of different types of balloon, and non-compliant, all sizes of the balloons, compliant balloons, high-pressure balloons, low-profile balloons. It's difficult to have all the consumable stock, but all the stock do have an expiry shelf life. That's why if you have a low-volume center, then it's difficult to have all the stuff. And then same for disposable and non-disposable stuff. Then everywhere in the world, particularly in Pakistan, you need to have a good alternate source of energy. Not just you have a generator, but I think you need to have that the generator takes a little while to kick in, but you need to have something like a USB or something that you don't feel a huge gap, as if there's electricity failure. We don't see electricity failure in UK, but I think in Pakistan is not uncommon phenomenon. So I think these are all important for patient safety point of view. We got to think about it. PCI or a complex PCI, it's not an ego issue. It's not a match issue for operators, first of all, and most important, the safety issue and for patient benefit. If it's not safe, it's better not to perform. Then also comes in, other than the cardiology, the cardiac surgery. Is a cardiac surgical opinion available, or is a cardiac surgery available all the time, or the ability of the cardiac surgical
Najib, you have 45
functional
seconds.
24/7? So that's also important. Then we also look at the other, is there an intensive care? The patient need a ventilatory support. They will be able to, a patient was able to go to ITU and ventilate. There is a radiology support.
Najib, you have 30 seconds, please.
Oh, okay. So I think these are things. And then if you have complications like vascular bleeding, and then you have and if you have other complications, then can you cope with this? And the same thing I talked about, the complex calcified lesions. Do you have a rotablator or complex lesion? You have guide extensions. So these are all important issues. You have emergency issue. And in Pakistan, there's another issue, the patient's portability. If patient is prepared to pay for one stent, but you have a complication, you need surgery, prolonged ITU care. So I think a lot of things need to be looked at. And again, certain complications, perforation and things, you need some stuff, but they again have a very short shelf life. So are you able to keep all them in stock, or like swan neck snare or tulip snare? So I think these are all important issues before in a low volume center you consider complex PCI. I think it's better to be avoided. Let's see what Rizwan says, but I think for me there is no brainer. I think complex PCI should be avoided in a low volume center where very few number of operators.
Thank you, Najib.
Thank you.
Thank you. It was excellent, but you only consumed 30 seconds of your rebuttal time also, so that's okay, no problem.
Thank you. Thank you.
So we'll move on. Dr. Rizwan Khalid is going to be talking against the motion. So Dr. Rizwan Khalid, on to you.
Assalamu alaikum and belated Eid Mubarak, everybody.
Yeah, we can hear you and we can see you very well.
I appreciate that, Dr. Khabar Kazmi. So I am going to, first of all, I appreciate the invitation from Dr. Hanif Bashir, Dr. Zubair Akram. It's been a pleasure always to participate in Pakistan Live and Pakistan Cardiac Society. And a lot of my colleagues are in the audience and are also panelists and chairpersons. So thank you very much for this very kind invitation. So since we only have 8 minutes, so I'm going to dive in it quickly and try to put up my point of view. So I am a partner in North Texas Arrhythmia and an associate professor of cardiology here in Dallas. And I will be taking the opposite point of view. So I do not have any conflicts of interest. So primarily, when we look at complex PCI, Dr. Najib, I'll make your life easier. I put in an AI, an artificial intelligence software, I put this question, and the software said that it should be, complex PCI should be done in centers of excellence. So we are done. The chat GPT, artificial intelligence, actually agrees with you. However, that's the reason why AI is still not mainstream, is because there are alternative point of views as well. So I think that many complex PCI can be done in centers that are not considered centers of excellence. However, with my colleagues and the fellows and young interventionalists out there, the most important message that I will give is that patient safety comes first. That's the single most important. I was part of the earlier session, the nightmares in the cath lab. Perforations and other complications in the cath lab. The most important thing whenever we do, it doesn't matter whether I'm in favor of this or I'm against this particular motion, but particular patient, it's not safe for me to do it in a center where I do not have the equipment or the experience. I 100% agree it should be transferred to somebody else or some other center. So it doesn't matter what my point of view is, patient safety comes first, always. The second point is there are complex lesions, and then there are complex lesions. Not all complex lesions are the same. So there are some complex lesions If you look by definition, even a STEMI is a complex lesion. It's a thrombotic lesion, and I'll go through that. And then there's complex lesion like last standing vessel, like an SVG intervention in a last standing vessel. That is much more complex. And you obviously need to first figure out what you're going to tackle and what you're not. Briefly, evolution of coronary intervention, the first time when an angioplasty was done, and in the very 5 years or so, a cardiac surgeon for simple angioplasty used to be sitting in the monitoring area. So we have come a long way since 1977, 1978, and we've made significant strides in the safety of interventional cardiology. And now in the US, we are actually not discussing whether centers of excellence should do PCI. We are discussing what procedures can be done in your garage, in an outpatient lab, in an ambulatory surgery center. This is the discussions in the US. Last but the least, I would say, show me the, in the US we say, show me the money. I would say, show me the data. Show me the data that centers of excellence do any better than another good center where PCIs are done. And that is what I'm going to do. I'm going to share the data. So this is the definition of complex PCI based on one of the perspectives. It could be bifurcation, more than 3 stents, a lot of thrombus-containing lesions, lesion length of more than 30 millimeters. If you're going to treat more than 3 lesions, CTOs, multivessels, left main, bypass. That was based on anatomical consideration. The previous one was anatomical considerations. Now you add equipment-wise what you require and comorbidities. Is the patient older? What's the patient's LV function? Does the patient have kidney disease? So then that makes a complex PCI. This is something that I would request everybody to look at. This is hard data, based on hard data, and this is actually endorsed by the British Cardiovascular Society, where Dr. Najeeb is a member of. This came out just 2 months ago, in February 2023, and was published in the Journal of Society of Cardiac Angiography and Intervention. It's endorsed by American College of Cardiology, the British Cardiovascular Intervention Society, the Canadian Society, and an Outpatient Endovascular Interventional Society. This is an extensive document. I think it was a great read. These are the key points that I would suggest that we consider. That elective PCI in a setting where you do not have surgery on site has increased in volume and complexity. And in addition, PCI now is being performed outside of hospital settings in office-based labs and ambulatory surgery centers. Several studies in the US and abroad have demonstrated that PCI performed at non-surgical site centers have very low rates of complication and similar outcomes to PCIs performed in surgical centers. Despite increase in age, comorbidities, and lesion complexities, the rate of periprocedural complication has remained constant or declined, with rates of emergency surgery as low as 0.1% in many series. So complex PCI, including unprotected left main, is being performed in some non-surgical centers with no increase in MACE or emergency CABG surgery compared to PCI at surgical centers. However, there are no comparative studies in other complex subgroups, and I will share that data as well. So I will skip this. I just tried to put studies. You will not be able to see this. This is, I tried to get all the data in which these are not center of excellence. These are just surgical sites versus sites that do not have cardiac surgery on site. Comparisons, numerous data, lot of data which suggest no significant change in mortality or morbidity. So what I'll do is I picked up a few of them and I will show large studies that showed no significant mortality difference in over 50,000 patients, 900,000 patients. You go down and you will see that there is no significant difference.
Sorry to interrupt, you have 30 seconds. Sorry to interrupt, you have 30 seconds to go.
Okay, so no significant difference. This is a study done in complex PCI from Australia. This one showed difference, 24 versus 12%, but a study done by the British Cardiovascular Society, huge number of patients, no difference. Lot of observational data which also shows that it's safe. Big research letter came out in one of the in JAMA that says that Centers of Excellence designation was actually challenged, and then numerous authors wrote, "Do cardiac centers of excellence really excel?" Lovely articles to read, but since I'm out of time, I would quickly go to my summary. That, in my opinion, patient safety first and foremost, no question about it. Experience of operator and cath lab is actually more important, in my opinion, than to do it in a center of excellence. If you have a good center, you have good interventional cardiologist, you have all the armamentarium, you can still do a lot of complex PCI in those hospitals. Obviously, not all complex lesions are the same, and most, if not all, complex lesions can be done in centers without surgery on site. Thank you. I really appreciate it. Thank you very much.
Okay. Thank you very much, Rizwan. Excellent. Najib, you have 30 seconds to say anything you want to say in rebuttal.
Yeah, Rizwan, thank you for your talk, and I appreciate that you also endorse the safety. That's why when I said the center of excellence, I think it's more important to have a high volume center. The surgical backup, I agree that Professor Bamas actually is my colleague. Some studies from our center. Okay, so that's why I think on-site surgery is one of the factors, but most important, the volume is more important. How many procedures you do? If you do very small number of procedures, then of course you won't have much consumable. Your cath lab staff will not be experienced in many other things, so which you don't need every day, but you do need it if there is a problem. So I think I agree the center of excellence definition is not correct, but therefore I think the volume is important.